Okay, we're starting Psychological Disorders Part 3, and as a follow-up to depression, as we're looking at psychological disorders, suicide is not a psychological disorder, although depression is a major risk factor for suicide. So are some other things like substance dependence and a few other severe psychological disorders also elevate the likelihood of suicide. Now, in terms of a few statistics about suicide, in terms of ethnic differences, the ethnic group who has the highest rates of suicides are Native Americans, and that's followed by people of European ancestry, Anglos, second most likely to commit suicide, and then Hispanics, Blacks, and Asians somewhat less than any of these. There are also some gender differences. As you see in the chart, males are more likely to die in a suicide attempt, even though females often do make more attempts. In fact, males tend to use more lethal means, guns or hanging, which is irreversible, whereas women tend to use pills or cutting themselves, which sometimes can be revived. Now, also age differences. In the chart, you will see that suicide amongst children is rare but non-existent. Rates do rise in adolescence. However, adults actually have higher rates of suicide than teenagers. That said, the highest rates of suicide are amongst elderly males. Now, that said, this data is a little bit old. What we would see is a little bit more of a bump in the middle age category. The number of people committing suicide in middle age has risen to some extent in the past few years. Now, there are other risk factors involved with suicide. We find that the wealthy, non-religious, people who are having relationship problems, and those that have a family history also are at higher risk of suicide. Now, if we encounter someone who is giving any indication of suicide, then we need to recognize this as a serious situation. The person who is threatening suicide, yes, they may be doing so as a way of getting attention, but even if that's the case, well, that person has a serious problem and needs some help. So, regardless if the person is threatening suicide, we need to assume that they may try to do so, and sometimes the threat is sort of implied. They might begin giving away their favorite items. They might be saying things like, "Oh, I won't be seeing you anymore," and they're not moving somewhere. They may suddenly give a change in their personality, a number of other indications that they may be suicidal. If this is an implied threat, then we may need to actually ask that person directly, are you thinking of harming yourself? Now, surprisingly, many people who are suicidal, when asked that question, will actually admit that yes, they are considering harming themselves and committing suicide. A lot of times people hesitate to ask. There's this idea that if you ask, you're going to make that more likely to happen. In fact, research indicates quite the opposite. It's when we don't ask, when we don't take implied threats seriously and investigate, that the person is more likely to actually commit suicide. So, in asking, you may do that person a great service. In many cases, the person actually does want someone to talk with them about their suicidal feelings. Now, in then discussing their suicidal feelings with them, one should express understanding. Yes, I can understand why you might feel that way. but immediately get them to focus on alternatives. Yes, you might feel like this is the only solution, but there's many other ways to deal with your problem. There's help available. And then we should move them to get them into contact with qualified professionals. Now, the people who have those qualifications have training and experience working with suicidal individuals. You might think you're good, or your family members you might think would be good, but let's face it, unless we've had special training in this area, we may not be aware of the best ways to help that person. Now, what kinds of professionals are qualified to help? Well, to intervene immediately in that crisis, law enforcement officers in terms of crisis intervention, as well as emergency medical professionals. Now, in terms of working with that person longer term to overcome the suicidal feelings, then we have the psychologist, clinical psychologist, the counselor. We have clinical social workers have training in this area, also psychiatrists, and some clergy, some pastors, priests, but not all have training in this area. So you have to be a little bit investigated and know whether your pastor or priest really has the background. There are cases where a person would rather talk to one of their religious leaders than, say, a psychiatrist. But try to get them to agree to talk to someone. Sometimes a good first step is to get them to speak to someone on a crisis hotline like you see, and then they will help get that person in touch with someone who can help them. Now, in fact, if the person is indeed suicidal and they refuse to avail themselves to any help, there is something you can do if they are truly making serious threats. We can call 911 and they can have that person, they might call it being hospitalized for observation, and they will be confined to the hospital. It varies. In some localities, it's 48 hours, some 72. During that time when that person is hospitalized, they will get them in touch with individuals who can work with them. And sometimes that person simply needs some time to sort out those thoughts. And we should also then accompany that person to seek help as well. So there is a lot we can do with a suicidal person, and it's good to be aware of what steps to take. In fact, as you address that, should you encounter it, you may be that person's lifeline. So do pay some attention to that. Now let's shift to something, well, not exactly more pleasant, but something different, schizophrenia. The name schizophrenia signifies a split from reality. So this is not a split personality, that would be dissociative identity disorder, but rather the person has lost touch with reality in some way. In schizophrenia, this severe psychological disorder, there are a wide range of symptoms that may be observed, such as disorganized or delusional thinking. The person may have delusions, beliefs that are contrary to reality, that are firmly held even when there's evidence to the contrary. Paranoia. The person may believe people are plotting to harm them, and there's no actual evidence of that. The person in their speaking may make no sense. It might even be called word salad, just a mix of words. They may give illogical or bizarre ideas, and there may be a disturbance of perception, hallucinations, which are false sensory experiences. Delusions of reference would be another perceptual problem. They believe certain things are referring to them when they're really not. Also, you might see inappropriate emotional responses and inappropriate behavior. We might see no emotional response to things normally people respond to, what they call flat affect. You might see constant silliness. You might see a lack of activity, catatonia, where the person remains frozen in some posture for long periods of time. You might see, again, illogical or bizarre behaviors, eating non-food objects or maybe masturbating in public or something. Um, Now, researchers have divided the symptoms of schizophrenia into positive and negative. Positive symptoms, there is something there that is in addition to what is normal or in excess of what is normal. For example, hallucinations, disorganized speech and thinking, delusional talk, irrational behavior, all things that would uh, be above and beyond what is normal. Negative symptoms, there is a lack, a deficit in some area, an absence of normal behavior, rigidity, sitting there motionless for hours, social withdrawal, which is quite common in schizophrenia. The person doesn't interact with others, may go into the room and avoid contact with others for days and days, or lack of volition. The person might lack the will for normal activity, might even refuse to bathe or get dressed. In terms of disturbed perceptions, hallucinations in schizophrenia are usually auditory, often take the form of hearing voices. Um, Less often, though, you may also observe visual hallucinations, somatosensory in terms of touch, or olfactory smell, gustatory taste. The pictures you see there, drawn by people with schizophrenia, might indicate how they at times see the world. And whereas it's fascinating to look at, also it would be quite difficult to function when your perception of the world is as they're seeing it in these pictures. The onset of schizophrenia and development of it, nearly 1 in 100 people suffer from schizophrenia, so about 1% of the population. This comes to over 24 million people worldwide. So, worldwide, quite a sizable group. Schizophrenia tends to develop as young people and adolescents mature into adulthood. Diagnosis of this peaks in the early 20s. Affects men and women in equal numbers. Textbook is not quite accurate there, but men tend to have the more severe symptoms. Depending upon how you look at it. We also may characterize the onset of schizophrenia as being acute or chronic. When schizophrenia develops gradually, it is likely to be chronic, and remission of the person's symptoms is less likely. The person also more likely will display many negative symptoms when you have the gradual chronic type of schizophrenia. On the other hand, when schizophrenia suddenly develops, we might call this acute development. Often this is reactive, seems to be a reaction to some event, stressful event or situation. Remission then of the symptoms is somewhat more likely, and where we have the sudden onset of schizophrenia, the symptoms are more likely to be of the positive type. Now, of all the psychological disorders, schizophrenia is most certainly an example of a situation where disease of the brain is exhibited in symptoms of the mind and behavior. Brain abnormalities observed in schizophrenia include dopamine overactivity. Researchers found the brains of people with schizophrenia had as much as 4 times the normal number of dopamine D4 receptors. They also have found abnormal patterns of brain activity in people with schizophrenia, particularly in the frontal cortex that has to do with thinking and reasoning, perception, and making sense of our environment, as well as the thalamus, which has to do with our sensory information, the amygdala, which has to do with our emotional responses. And as you can tell from that, many of the symptoms of schizophrenia correlate with the parts of the brain that would connect with those symptoms. They also have noted that there is loss of brain tissue in schizophrenia. As you see in this picture, abnormal brain morphology. And in analyzing the brains of many people with schizophrenia and comparing those to those who did not have schizophrenia, they noted that on average these ventricles were considerably larger, would suggest that the amount of brain tissue has decreased. Now, there is some interpretation of this by some that, in fact, this difference that was noted here might be due to the long-term exposure to antipsychotic drugs rather than schizophrenia itself. Many of the people who were part of that study with schizophrenia had been on those medications for long periods of time. So that one, we might say, well, maybe that's the case in schizophrenia always. Maybe it's an artifact of the medications that may be used by many of these people. They have looked for factors that increase the risk of developing schizophrenia prenatally, before that person is born or around the time that they're born. A few things seem to increase the risk. However, recognize that, for example, one of these factors might increase the risk from 1 in 100 to maybe 1.5 in 100, or maybe 2 in 100. So these by no means mean that the person automatically will develop schizophrenia. However, these are more commonly found in people who develop schizophrenia. They see this more often in people with low birth weight, also where the person was deprived of oxygen during the delivery process, anoxia. Childhood malnutrition is present in the background of more people with schizophrenia than the general population, as well as the mother developing influenza during the middle trimester of fetal development. Once again, we should recognize this increases the statistical risk somewhat. Again, that said, just because the mother gets the flu while they're pregnant by no means that their child is going to get schizophrenia, just simply elevated risk. Now, genetic factors do seem to be quite significant, and in looking at the chart, an individual identical twin who suffers from schizophrenia, their identical twin has about a 50-50 chance of also developing it. If both parents have schizophrenia, also nearly a 50-50 chance, somewhat less if there are other family members who have developed schizophrenia. Now, that said, even with identical twins, notice that 50-50 chance the other twin develops it. In fact, that other 50% would suggest that there is also significant influence of environmental factors. Some of them, which we already mentioned, the prenatal and While we're talking about schizophrenia, we also should mention that um, people with schizophrenia from at certain times may appear to be completely normal. At other times, their symptoms may be more evident. We'll talk about treatment of schizophrenia in the next chapter. Moving on to the last category of psychological disorders, we come to personality disorders. Personality disorders differ from those that we previously encountered. These are inflexible and enduring patterns of behavior that impair the person's functioning and particularly interfere with social functioning. And so these are behavior patterns which the person is unwilling to change, inflexible, enduring. The person does not evolve into other behavior patterns, and they may interfere with the person working effectively, uh, particularly impact their relationships with others. Now, the difference here between these and our previous disorders, the other disorders, people don't see them as being part of their personality and who they are as a person. The person with depression does not see that as part of their identity, but rather something that they have that they'd rather not have. Um, with personality disorders, the behavior becomes part of the person's identity. And we might suggest to that person to change the behavior pattern, and they will refuse. They'll say, no way, that's part of who I am. If I change that, I would not be me anymore. Personality disorders also differ in that the person with these disorders generally does not experience distress to a great extent. Usually it's the people around them that suffer. With the previous disorders, yes, the person themselves is the one who generally feels the distress. Now, because people with personality disorders don't feel distressed by them, they don't benefit generally from therapy. We might suggest that they get some help in changing their behavior, and they'll say, no way, I'm fine. I'm not the problem. Rather, everybody else is the problem. And they generally will point to everybody else is the cause of problems, not their own behavior. They have divided these disorders into three categories: eccentric, fearful, and dramatic and impulsive. And I'll give you an example or two of each of these. In the eccentric category, you would have schizoid personality disorder. And we have here a person that simply lacks interest in relationships with others. They don't particularly form friendships. They don't really bond with others. Now, this is different than autism because they develop the language skills and so on, but the person is just generally disinterested in interaction with others. Um, we then have in the fearful category avoidant personality disorder. In this situation, the person avoids any situation where others might ridicule them, make fun of them. Um, their behavior then becomes, their activities become very restricted as they avoid. There's not very many things you can do where there's not some potential to be ridiculed or made fun of, that sort of thing. Then we have obsessive compulsive personality disorder. This differs from the previous obsessive compulsive disorder that we studied, whereas obsessive compulsive disorder, there are specific obsessions and compulsions. The personality disorder with this name denotes the person who is obsessed with control. So there's a generalized need for control. That person, um, if you're around them, you must do things their way. Uh, you can tell them there's better ways, they're not going to listen to you. You can have an argument with them about how to do things, but in the end, you're either going to do things their way or you're going to go your own way. They won't tolerate others having any control over situations. So these people that are obsessive compulsive personality disorder, kind of control freaks, often drive the rest of us kind of crazy if we have to be around them. Then in the dramatic and impulsive category, some examples would be histrionic personality disorder. Here the person will blow any situation into a dramatic sort of situation, into a major drama. And they often also have an inordinate need to call attention to themselves and be the center of attention. And they'll do so even in the most inappropriate situations. Again, very difficult to be around. And if you'd like to see some of them, well, yeah, tune in some of those reality shows or novellas, and you'll probably see some people that might fit that description. And by the way, I should mention personality disorders are relatively common. So, yeah, there's a good chance that somebody that you know might suffer from one of these, or maybe we should say the people around them suffer. Uh, Narcissistic personality disorder. This is a disorder in which the person becomes completely self-centered. It's everything is all about them, and they don't have much interest in the feelings of others. They often have some grandiose goal in mind. And what are the rest of us here for? Well, we're here to serve them so that they can achieve this grandiose goal. Um, they generally don't make real friends. They're simply interested in using others to achieve their goals. Then we have borderline personality disorder. This is one I'll say a little bit more because this is one of these that causes people even greater difficulty than most. In borderline personality disorder, the best descriptor of that person would be unstable, and instability in all areas of life characterize that person. The person has an unstable identity. They don't deep down know who they are, and so they may latch on to others to derive some sort of identity through that relationship with others. But because they're also unstable emotionally, they may be very happy with that person and loving one minute, and the next minute flying into a rage and back and forth. The other person often gets tired of that pretty quickly, breaks up the relationship. Now that person with borderline personality disorder has lost the foundation of their identity. And so they may go into extreme behavior trying to regain that person's relationship. They might threaten to kill themselves if that person doesn't come back to them. They might engage in false suicide attempts, or they might engage in self-destructive behavior, trying to regain that person's relationship. They're also very unstable in many other ways. The person more prone to substance abuse problems and um, also self-destructive behavior. So here is one that tends to cause others around them a great deal of trouble as they try to deal with this person who is so erratic in their emotions, behavior, identity, all areas of life. The last person Disorder that we'll take up is antisocial personality disorder. And we'll spend more time on this one as well because this tends to have greater implications for society. Now, the first thing that you should get in mind here is that when we have antisocial here, this is not about someone who mm, is afraid of others or who does not interact with others. In fact, many people with antisocial personality disorder are very much involved with interactions with others, generally have no fear of others, in fact, may be quite fearless of them. Antisocial in this case means that they do things against others. They're against others. Okay, so antisocial. This person may harm others. They do so with a lack of remorse. They don't feel sorry for the harm that they've done, the wrongdoing. They don't have any empathy for the suffering that they've caused their victims, and they have generally poor judgment, so they're indifferent to the consequences of their behavior. You might tell that person, well, you know, you're going to go to prison or maybe get the death sentence if you do that, and it doesn't make a bit of difference to them. They tend to be irresponsible and untrustworthy, and in some cases, though, they are able to sort of hide those tendencies in order to get themselves into positions where they can more readily harm others and take advantage of them. The person with antisocial personality disorder might be just a common thug that harms other people, or if they happen to be highly intelligent, they may play the part of being friendly and charming, get other people's confidence, and then take advantage of them. So, whereas you think they are trying to be your friend, in fact, they are really plotting to do you harm or take advantage of you. That's why sometimes these people may be called a con man. Now, the term sociopath or psychopath has been used for this personality pattern previously. The usage of this words haven't been real consistent, though. In general, we would say the sociopath is one who is less able to hide these tendencies, simply out and out mean to a greater extent. The psychopath is the general use of this is the more devious person with antisocial personality disorder that may be able to disguise their intentions more readily to harm people. Now, in trying to understand what contributes to the development of antisocial personality disorder, researchers learned that a fearless temperament is very commonly part of the picture. The person has chronically low levels of arousal, might be seen in terms of brain activity, blood pressure, slow heart rate, indicating that the normal levels of stress hormones are not being produced. And in fact, when put into stressful situations, the arousal of the sympathetic nervous system in these individuals is much less than it would be with the rest of us. And so, when put into situations that are dangerous, the person remains much calmer than the typical person. And because of that low level of arousal, then that person may engage in criminal activity and harming others simply for stimulation. And they would say, well, why did you steal all that stuff? Well, I don't know. I was just bored. Or why did you get in a fight with that person? Oh, I don't know. Things were dull. I just wanted to stir up something. Now, temperament is to a great extent built in, uh, based on sort of genetic factors to a great extent. And so you might think, oh, well, is it inevitable that a person that is has this temperament is going to then become one of these kind of people? And it turns out not necessarily. In fact, others who have this sort of temperament may do very positive things if they channel this temperament into positive outlets like heroism or adventuring, the person can do a lot of good having this type of temperament. But where the person does not have a positive outlet for that, then they may turn to harming others for stimulation. Now, they also noted that the brain activity of those with antisocial personality disorder seems to differ. In studying PET scans of numerous murderers, some of which had antisocial personality disorder, they found there was reduced activity in the frontal lobes, which helps us to judge the consequences of our behavior, as well as to resist impulses that we might have. And follow-up study indicated that repeat offenders had 11% less frontal lobe activity, so there may be some differences in brain activity. This may also go along with maybe some subtle brain damage that's occurred. We will then go on to the next chapter on therapy when the time comes. So hope that worked for you. And that's it. The end of this chapter.